So, to just sort of hyper focus on one little quick hit topic, I feel like a lot of you have been telling me stories about patients that have had really difficult vascular access. I heard about a bad traumatic arrest where, the nurses couldn't get a peripheral IV. And so we just drilled him, we transfused him through there. I heard about another patient with really profound hypoglycemia. And so I just wanted to touch base on sort of emergent vascular access in really critically ill patients, in crumping patients. And so the goal for this little 5-minute session is so when you are in a resuscitation that is busy and chaotic with a very, very sick patient, when the nurse comes up to you and says, I can't get the IV, that you have an algorithm and you have a couple little extra tools in your tool belt to use. I feel like this is where most of our brains go when the nurse says, I can't get the IV, or this is our vascular access algorithm in the resuscitation bay. First, we rely really heavily on our nurses to get an IV. And then if that doesn't happen, usually someone's yelling, all right, let's go get the ultrasound, and we fish around there. And then when that fails, I feel like a lot of us are pretty quick to say, all right, this is an indication for central access, or let's just put an IO in and start infusing through there. And that's all well and good, but I want to refine this a little bit more. Maybe we can work together to get a couple extra pieces into this algorithm. So first of all, let's just knock nursing IV off of this algorithm, right? Like that shouldn't be part of your algorithm. The only time you should be accessing this little stepwise approach is if nursing can't get the IV, right? This is the physician vascular access algorithm. So when the nurse says, I can't get the IV, the first thing that I think of is, can I get a regular peripheral IV like the nurses do, but at an atypical site? And we'll talk about a couple of my favorite ones in just a minute. If that doesn't work, then I typically move on, grab the ultrasound. And then my next step, or maybe even before the ultrasound peripheral IV, is to do something called an easy IJ, which when I learned about this totally changed how I approached vascular access in resuscitations. And then if that one fails, then I move on to central access or IO access. So let's talk about the first little pearl. Let's talk about atypical sites. So one of my favorite atypical places to look for an IV is, you guessed it, or probably not, the feet. I love looking for the feet. Go ahead and peel off those 4-day-old hospital socks and see if there are any big juicy ones floating on the dorsum of the feet down there. You'd be shocked at how many regular IVs you can just cannulate down there if people haven't already looked. The feet are also a really good place to look in pediatrics. This is kind of a go-to spot for really, really small children, like less than 6 months. It's this saphenous vein that rests just anterior to the medial malleolus, and you don't need an ultrasound. You don't need anything. You just need a tiny little baby IV, and you start poking around until you get a flash. So when the nurse says, I can't get the IV, I'll often start looking down at the feet, down at the ankles. And then if that's not there, another place that people love to go is the external jugular vein. This is a great line if you can get it. Can be kind of tricky sometimes. So if you're going to go for an EJ, go ahead and lay your patient flat, go ahead and put them in Trendelenburg. And if they are not obtunded and not comatose, you can have them Valsalva, you can have them hummed to try and make that a little bit easier. Some people try and get really fancy and they sort of bend the tip of the catheter into like a little bit of a hockey stick, almost a little bit of a curve on there to make it really, really shallow to get into the neck. So that's the atypical site. And now we're going to talk about the other pearl of this quick hit, which is the easy IJ. And all an easy IJ is a peripheral IV, regular ultrasound IV, but you're putting it in the internal jugular like you're doing a central line. You only need a couple of things for this. You need your ultrasound length IV, your 18 gauge IV. It's 2.5 inches. Grab an ultrasound probe, and you can grab a tegaderm as sort of a pseudo-sterile probe cover, if you will. After that, you grab a little bit of sterile lube and then a ChloraPrep. Okay, and then you're ready to go. So then you go up to the patient. Guys, I'm so excited for this animation. Wait, check this out. You go up to the patient, you prep the neck. Oh my God, that was so good. Hold on. Wait, can we do it again? We're going to do it again. You prep the neck. Oh my God, so good. And then you put the probe on with your sterile jelly, and you just go ahead and cannulate the internal jugular vein like you're doing a central line but with a long IV catheter that you would use for any other peripheral IV. This is not a sterile procedure. You do not need to drape the patient, and you do not even need to put on sterile gloves. This has been studied. It is a really nice line to have in your back pocket if someone's super hypotensive and there's nothing peripherally, if they're in hemorrhagic shock, if you need something a little bit beefier to infuse a little bit faster, and we don't have a bunch of time to set up for a central line. So I hope this was helpful. Little vascular access quick hit. Let's just do our takeaways real quick. When the nurse says they can't get an IV, first just try and do a regular nursing level peripheral IV and look in a couple of your atypical sites. Look in the feet. Go ahead in babies, try and poke and get that SAF. And then look at the EJ. Lay your patient flat and put them in Trendelenburg and see if you can grab it that way. After that, grab your ultrasound, or if your patient's really crumping and they're not going to have anything peripherally, go for the easy IJ. Go ahead and take a long ultrasound length IV catheter and just stick it in the IJ like you're doing a central line. Put a little Tegaderm over the ultrasound probe, put some sterile jelly on, and go to town. It's a great line. And then if all of that fails, head over to the central line, head over to the IO. And of course, you can always reserve the IO if someone is imminently crashing and needs medication, like right this very second. But if you can get vascular access into the bloodstream, I think most of us would agree that that's a better route. Hope this was helpful. Would love to hear any feedback, any debate, anything you disagreed with in this presentation. Feel free to email me and let me know if you have any other requests for any quick hits. And I'll see you guys on shift.